Martin, are you ready? Can we start in a minute?
Yeah, can you hear me?
Yes, I can hear you nicely. Give me a minute
Okay.
to just introduce you, and then I will invite you to talk.
Okay. Good afternoon, everybody.
No, Martin, just give me another. Sorry, Martin.
Yes.
Sorry, just give me another minute to introduce you, and then I will invite you to talk. Just give me 1 minute.
Good.
Okay. Good afternoon, everybody. Welcome to our Zoom academic meeting of the Department of Pediatric Surgery in East London, South Africa. And I am really honored and privileged to have Professor Martin van Niekerk, who is a senior pediatric surgeon and pediatric endoscopic surgeon who practices in Pretoria. He is also affiliated to the Steve Biko Hospital in the University of Pretoria and has a big private practice in Kloof Mediclinic in Pretoria. He is one of the most experienced and skilled pediatric laparoscopic surgeons I know of. And he is not only skilled and experienced, but he is extremely modest and does not like to talk much about his own work. So in addition, he is a very close friend, and that is why when our registrar was unable to give her talk, he immediately agreed that he will prepare a talk at a very short notice, and he will give a talk on his own, which we sincerely appreciate. So without further introduction, I invite Professor Martin van Niekerk to share his knowledge, expertise, and pearls of wisdom with us. And the topic is gallbladder, a gallstone disease, and related problems. So Martin, please, you can start.
Thank you very much for the kind words. I must say I started off by doing general surgery and pediatric surgery, and it was in the late 1980s. So it was just when laparoscopic surgery starts going. So I did a lot of cholecystectomies and things like that. So I've got a lot of experience with cholecystectomies. These days, obviously, it's not a common condition or a common operation that we do, but I think we should know exactly what to do and what are the pitfalls and things like that. So, yeah, I just want to say I had quite a short notice to prepare this thing, so it's not very professional, but I'll try my best. And I want to try and make it a little bit practical, but we start off by a few things about gallstones, and then I'll do my talk, and then you're welcome to ask me any questions. I just want to see if this thing will move. Parrot. Let me just see if I can get. Parrot. I tried to get. Just want to see if I can get my slides moving. Yeah, sorry for the delay. Yeah, gallstones is, as you all know, quite common in adult patients, less so in children. And the prevalence rate in children is about, as you can see there, about 1 or 2%. It depends where. Obviously, in the East, like Japan and so on, there's much more gallstone problems and bile duct problems. And in neonatal gallstones, the percentage that they give is about 0.5%. This is just from the textbook that I've the different reasons for gallstones, and you can see there on the top the hemolytic diseases, congenital prematurity, and those sort of things. Genetic plays also a role, and then dietary like obesity and insulin resistance, and then certain medications, surgery, especially excision of the terminal ileum, Crohn's disease, and so on. And then and the last one is biliary dyskinesia, which is a common reason for cholecystectomy, especially in the United States. And this is also from the textbook, the different gallstones. I think pigment stones, the black pigment stones are the most common that we see, but we see also a lot of cholesterol stones. And there you can see the association with obesity and the genetic mutation there. And then the pigment stones, which you see with hemolysis and parental nutrition, and the brown pigment stones and the calcium stones that we get. Yeah, the clinical features, most of them are asymptomatic. I must say, in my practice, most of the times the child presents with abdominal pain, mostly not associated actually with cholecystitis or anything. And then they pick up the stones. And what's also interesting is if you get a child, an asymptomatic child with gallstones, at least 50% of them, if you repeat the sonar, nobody sees that gallstones again. So I think it's a good thing not to do a follow-up ultrasound before you start any treatment, and especially not taking out the gallbladder. And then, yeah, the symptomatic part is this cholecystitis with Murphy's sign. That's about 8% of children that develop, yeah, that we see. And then cholangitis is about less than 10%, pancreatitis less. And then in very small children, it's non-specific abdominal pain and so on, that puts you on a track that there's something going on. Biochemistry, the usual tests, you all know it's a liver function test. We do the amylases and the full blood count, obviously. And the radiology, obviously ultrasounds, but there's also a place for MRCP. CT scan is also a good thing to pick up gallstones. And then the ERCP, where you can pick them up when you do an ERCP. And it's also to treat gallstones sometimes. Medical management, I don't want to say much about that. Ursodeoxycholic acid, they sometimes use, but I've seen a series where about 60% of the patients became asymptomatic, but only 6% of the patients, the gallstones disappear. So you can maybe try that, but and then also obviously the shockwave lithotripsy, that might have a place in the treatment. And then about cholecystitis and stones in the common bile duct. If you really want to see what's going on, you can go to the Tokyo guidelines. It's for adult patients, but the treatment in children is basically also the same. So I just going to quickly say, if you suspect stones there, then you will the liver functions will be abnormal. You maybe will have pancreas enzymes that's raised, and then you'll see the common bile duct stones on ultrasound maybe, or a dilated common bile duct. And if you have the stones there, obviously, if there's stones in the common bile duct, we also like to do a ERCP with a sphincterotomy, and then after that do the cholecystectomy. If you look at on the right side, there's a diaphragm that they show when you have cholangitis. Obviously, the first line of treatment is medical treatment with antibiotics and fluids and so on. And then after that, ERCP or cholecystectomy, whatever. But if the patient is not in a good condition or don't improve on medical treatment, then sometimes you can do a ERCP to clean the common bile duct, or you can do a cholecystostomy in a child and rinse out the gallbladder and the common bile duct or drain it. Interventional radiologists are sometimes used to put a pigtail into the gallbladder to drain the bile, and that sometimes helps for the cholangitis. Post-op complications, bile leak can be secondary to a common bile duct injury, but many times it's just small bile ducts in the bed of the gallbladder that leaks a little bit of bile. Sometimes even the cystic duct, the clips can maybe come off or whatever, and then you can also have a bile leak. That's why in many patients, especially if it's a difficult gallbladder, I sometimes put in a drain, and we use a HIDA scan to diagnose where what the situation is, and sometimes we do a ERCP if it's a problem to improve the bile flow, and that sometimes helps to stop the bile leak. And then retained bile stones is a complication. Strictures of the common bile duct secondary to surgery is maybe a problem. And then post-cholecystectomy syndrome that you get in adults. That's a patient that had a cholecystectomy but persists with the same symptoms. That's called the post-cholecystectomy syndrome. And then I just want to say a few things about the surgery. The common approach is the 4-port approach, like that on the screen. So it's the camera port. In most of the cases, we use a 5mm 30-degree lens. And then you have an epigastric port there in the epigastrium. And then 2 other ports. The one next to the umbilicus and the epigastric ports are your working ports. And the camera port and the very lateral port is the port for the ports for the assistant for the camera, and the assistant also catch the fundus of the gallbladder and pull it superior, sometimes over the edge of the liver. And most of the surgery is done with that epigastric port. We do the mobilization of the gallbladder. We do the clipping of the bile duct and the artery from that port. The other port is just for traction on Hartmann's pouch. So what you do is, after you've placed the camera port, the other ports are placed under vision, and then we start by removing all adhesions, and then grasp the infundibulum of the Hartmann's pouch with your left hand, and then do the dissection or the clearing in the hepatocystic triangle to try and identify the ductus, the duct, the cystic duct, and also the artery, and then clip those. So this is just a few pictures. This is not just to show you how it looks. I think most of you have seen a cholecystectomy. This is just I think the clips on the artery or ductus cysticus. Arteries clipped there, and then the cysticus, which is usually the inferior duct. Two clips were placed there, and one close to the closer to the gallbladder, and then you just cut it through with scissors. Yeah, this is the bed of the gallbladder. After you've removed the gallbladder, you quarter a lot there to stop any bleeding from that. I just want to show you you've got actually two triangles. The one is the hepatocystic triangle that you can see there. It's the blue and the yellow. And the enclosed triangle is just a yellow one. Some people feel that both of them are called enclosed triangle. But I think the right way is to say that the whole thing there, blue and yellow, is the hepatocystic triangle. And just that yellow one is enclosed triangle. So the idea is to pull on the gallbladder on the top, on the fundus, by the assistant. And also you pull on the Hartmann's pouch and pull it to the lateral side so that you can open the space, the hepatocystic space, and then you clean it there from fat and everything, and so that you can identify the cystic artery and also the cystic duct. One thing that's important is the triangle of safety that everybody is talking about. And that triangle is, how you do that is, there are three things. That hepatocystic triangle is cleared of fat and fibrous tissue. And you must loosen the lower third, or at least a centimeter of the gallbladder from its bed. And then after you've done that, two and only two structures should be seen entering the gallbladder. So that's the critical angle that we talk about. On this pictures lower down, you can see the bile duct and the artery from the left and from the right side. What I usually do is I mobilize, I pull on the Hartmann's pouch, I mobilize the cystic duct, which I think is the cystic duct, and then I clean it so much that I can clearly see it goes into the gallbladder. And then I go up and then I identify the artery. And once you've done that, then you can start clamping those two structures. Sometimes, if you have a difficult situation, there's a lot of adhesions and inflammation, you're not sure what's going on, you can do a subtotal cholecystectomy. Now, these are the sort of landmarks that they talk about. This is Rovier's, that RS with the four arrows, is Rovier's sulcus. It's just the impression on the right lobe of the liver. And then you can see the line going up there to segment 4 and also to the falciform ligament in that area. The area on top of that is the safe area, that blue with the T and the gallbladder. So if you stay on top of that area, you can do a subtotal cholecystectomy and either close that little bit of distal gallbladder, or just leave it open and remove the mucosa. And if you want to, you can put in a stitch where you think the cysticus comes into the gallbladder or not, and then you just put a drain in that area. So that is called a subtotal cholecystectomy if it's really difficult to see what's going on, and you don't have this triangle of that view of safety. Other people also use this, what they call the D line. There you can see that white line, and that white line runs through the base of segment 4 and also to the falciform ligament. It's basically the same line as the previous one. And then there you can see, then they open that area there on the white line. So that's a very safe area. And then you can go distally and identify the cystic artery and the cystic duct and things like that. This is especially useful if you have aberrant arteries or bile ducts. I must also say that one of the problems is that there's a lot of variations in the anatomy. The normal, what we call the normal cystic duct is only normal in about 50% of cases. In the other 50% of cases, there are different variations in the anatomy of the cystic duct. This also leads to many. This is also a factor that might lead to injury of the common bile duct and so on. And then if you have some people do a cystogram for every case. I don't do it. I almost seldom do it. If you don't know about the anatomy, you can do this gram. There are two ways. You can open the cystic duct itself, just put a clip distal to that and inject the contrast, or you can put a clamp over the distal gallbladder, put in a needle and do the gram. So that will help you to identify the anatomy better. The other thing that they say is safer is to remove the gallbladder from the fundus down. So it's the fundus approach. So if it's a difficult gallbladder, you remove it from the fundus side. I just want to show you that it's also can lead to damage. So if you can't see what's going on there distally, just remove as much as of the gallbladder as you can safely, and then just close the gallbladder or just remove the mucosa. So the fundus down procedure to take out the gallbladder is maybe safer, but it also can lead to injury to the common bile duct. As you can see here on the second picture, if you go down there, you will injure the common bile duct. And then the new thing that we have is this ICG, what we call this indigo cyanide green or near infrared fluorescence image that they use these days. It's if you do robotic surgery, then the whole system is called the Firefly. On the 4K camera, it's called the Rubina system. So you inject this fluorescence fluid, and then it shows the bile ducts and things like that. We are getting the 4K camera now with this fluorescence, so maybe I can show you next year how it's working. But this is the new buzzword, is the ICG, the indigo cyanide green imaging or fluorescence imaging. It's used for many things. It is only excreted by the liver and by the bile ducts. And so if you want to see pathology of the gallbladder or the bile ducts, you have to inject it 6 or 10 hours before the operation. If you want to see the arterial blood supply, then you can just inject it a minute or so before you want to see. What is nice previously, if you had the system on your camera, if you switch on the system, the rest of what you see is black and white. But with this new Rubina system, the color and the picture stays the same, but you can see this green image then of the thing that you want to see. It is used for quite a few things. You can use it for the liver metastases, partial nephrectomies, partial splenectomies. you can look at the blood supply of the bell that you want to pull through or whatever, to see if the blood supply is good. It can be used in NEC patients to look at the blood supply. And it's also used in things like varicoceles. If you inject it in the testis, you can very nicely see where the lymphatic system runs, and then you can just tie off the artery in the vein and keep the lymphatic system, and that will prevent your patient from getting a hydrocele post-surgery. Yeah, I just want to say a few things because it's important. I think maybe you all know the system already, but ICG is a fluorescent dye which is used in medicine as an indicator substance. It is inert, non-radioactive, non-toxic, and water-soluble. And after IV administration, it rapidly comes down to albumin, and it is nearly instantly recognized within the vascular system of the target organs. And the half-life is about 150 to 180 seconds. What it's also used for is for any malignancy. If you inject this, the lymph nodes that are involved, or the whole lymphatic system shows up, and then you can know where to remove, and when you want to remove the lymph nodes and things like that, you can nicely see it with the system. And as I said, it's 1.2 or 0.1 to 0.2 milligrams per kilogram. And actually, it should be injected 6 to 10 hours before the procedure if you want to see the extrahepatic bile ducts. And yeah, as I've said, within 60 seconds, you can see the blood supply in that area if you inject this contrast. Yeah, renal surgery, tumors, lymphomas, varicoceles, gallbladder pathology. So there's a wide range of possibilities to use it. And then, yeah, the next thing I want to say is the 3D camera can also be used to take out the gallbladder. We have a 3D camera. It's very nice to remove the gallbladder with a 3D. The problem with the 3D camera is that it doesn't have a 30 degrees. It's just a 0 degree lens. So it gives you depth perception, but not as good as a 30 degree lens. So most of our operations are done with a 30 degree lens, which we don't have with 3D. So I think it's not that worthwhile getting a 3D to do your Nissens and things like that. If you're also not used to work it like me, to work with it like me, I've worked for years with 2D, so this 3D just gives you a headache, you know, that sort of thing. So that's a situation with 3D. Then I also, everybody wants to, there's a 2-incision also method that we do, and that we can do. And Rothenberg does it with a 2-incision method. So we all want to become Rothenbergs, but he used an umbilical incision and epigastric incision. So the epigastric incision is a 3 millimeter incision, and he uses 3 millimeter sealer for that to do most of the work through the 3 millimeter epigastric port. He also seals the blood vessels and does most of these sections with the epigastric port. The umbilical port is then used for the camera, a 5 millimeter camera. And then he has another 5 millimeter port in the umbilicus. And then he also uses 2.5 millimeter mini grasper in the umbilicus between the two 5 millimeter ports. So this is Stephen Rothenberg does his cholecystectomies with 2 incisions. Yeah, that's what I said. Most of the section is done with a 3 millimeter sealer. And these, he removes the gallbladder with a small endo bag via the umbilicus. If we do the standard sort of cholecystectomy, we only remove the gallbladder through the 5mm incision in the epigastrium area. You grasp the gallbladder near the clips and you bring it out to that area. You can enlarge the incision a little bit, then open the gallbladder, suck it empty, and then easily you can remove it through the epigastric incision. Many people remove it to the umbilicus, through the umbilicus, but it's also nice for me to keep the camera in the umbilicus and just remove it through the epigastrium port. And we don't use actually an endo bag to remove the gallbladder. I used to do a lot of single incision laparoscopic surgery. These days I do less of that, but we've done quite a few gallbladders laparoscopically. Pyloric stenosis is also a nice operation to do single incision. And then the Morgagni hernia is also sort of a nice operation because it works straight forward. So you can do that. And then we've done pull-throughs for Hirschsprung or imperforated anus, also single incision. I haven't done a splenectomy, but there are people that also do even a splenectomy single incision. But I think the most important one is probably the cholecystectomy that you can do single incision. Yeah, we do. I forgot about the ovarian cyst and a lot of other things. But some surgeons do single incision for the to remove the gallbladder. I just want to say a few things about the single incision laparoscopic surgery. It's obviously it's just a single incision through the umbilicus, and the aim is to sort of have scarless surgery because your umbilicus is sort of a natural scar, and so it's the only use for the single incision is just to try and improve maybe cosmesis and maybe decrease analgesia requirements, but the incision through the umbilicus is quite big, so I don't think there's much of a decrease in analgesic requirements in these patients. And obviously, traction is a problem with the single incision, and the close alignment of the camera and the instruments results in a loss of triangulation. So it makes it a little bit more difficult to take out the gallbladder with a single incision. Johnson & Johnson has the single incision, they call it the Sols port. It's a single port that they developed with all the instruments that you can put through this port, and they patented as the Sols port. That's very expensive. So all the single incision operations that we did, we only use standard instruments to do the operation, and also for the to take out the gallbladder, we used standard instruments. We use, as I said, only what we usually do is we put a stitch from the outside through the fundus of the gallbladder and bring it out to the abdominal wall and tie it over a swab, and that is for traction. So we put a traction suture from the outside for traction on the gallbladder. And then for the rest, we use a 5mm camera port, a 5mm working port through the umbilicus, and also then a 3mm port also through the umbilicus, mainly for the traction that we can get from that. This is the sort of incision that you can make for the single incision. It's a vertical or a transverse incision. And then you can see there, you can extend it a little bit so that you can have more space in the umbilicus to place your ports. We just use stab incisions through the ports with instruments, or sometimes we put ports, real ports through those stab incisions. And the Storz rotor locks are quite nice because the heads are quite small. So especially for thoracic work, we also like to use the rotor locks. Yeah, there's on top transabdominal PDS suture directly to the abdominal wall and through the gallbladder fundus for traction, and the rest is as I've described it. Yeah, again, this is just to get better cosmesis. It's quite difficult. It's much more difficult with longer operation time, and maybe an increase in bile duct injuries because we don't have much traction on during the dissection. This, I just want to show you two pictures. You can see, unfortunately, if you put a stitch through to the gallbladder, then there's a leak of bile the whole time. So everything is a little bit covered with bile. You can see there's the operation with the clips that we've placed there. So this is this single incision laparoscopic cholecystectomy. Then yeah, I actually wanted to show this case, two cases, and wants to hear what you say, but I present it and then maybe somebody can comment on that if they want to. The first patient I want to present is a 5-month-old male patient with a month history of abdominal pain, pale stools and dark urine. He had a known history of, well, he is a Prader-Willi syndrome patient, and he presented with, as I've said, dark stools, jaundice, and dark urine, pale stools, and jaundice. And his conjugated bilirubin was 484, his total. Not sure what the conjugated was. We did an MRCP on this patient, which showed gallstones. So this patient is 5 months old. He's got gallstones in his common bile duct. And he's got this jaundice, the whole thing. What are the options on? We don't have. We can do ERCPs for a child that's older than 1 year, but this one was 6 months old. So what to do for this child? So what we do is, what we did on this child is we did a laparoscopic cholecystectomy for the child, and we place a catheter in the gallbladder. I'll show you now. And what we did then, we tried with Fogarty catheters to try and get that gallstones out. We tried pushing it down. We tried to, with a Fogarty catheter, to get it out through the gallbladder, but nothing was successful. So we couldn't relieve that obstruction or take out the gallstones through that cholecystectomy. So what we did is we put in some MTBE. It's an ether substance. It's called, what we use is methyl butyl ether. It's called MTBE through that catheter. And yeah, we put in 1 cc, and the next day we put in another cc, and this dissolved all the stones dramatically. And this is the post-MTBE X-rays. We kept the catheter in, so we did a gram after a few days, and it showed that all the gallstones were gone. Yeah, this MTBE, you can see that it's this last one on this chart, and it was used in the 80s for gallstones. It's not used much more anymore, but it was a thing that we use in petrol to decrease the emissions. But because it also polluted the groundwater, they abandoned the use in petrol. And yeah, we've used this, and it had a dramatic effect to dissolve the stones and solve the problem. there's quite a bit in the literature on this, especially in the 1980s literature. And then the next case is this 3-month-old male patient with obstructive jaundice. It was total bilirubin was 66, conjugated 44. And we did a ultrasound on this patient, and it showed a normal gallbladder, dilated intrahepatic bile ducts, and dilated common bile duct. Again, the child was 3 months old, and we did a cholecystectomy again on this patient with a gram, and it showed this isolated benign stricture in the common bile duct, quite distally. And what we did then is to dilate the stricture over guide wires through the cholecystectomy. And this solved the problem. We did a follow-up gram also a week or what later. That was normal. We've seen the child 6 months later with no problems. So that was a sort of a nice way to treat a benign stricture in such a small child, just by doing a cholecystectomy and dilate it through that cholecystectomy. Thank you.
Martin, thank you very much. That was absolutely fascinating. And I mean, you have gone from the basics to the most advanced things, which just make me say, wow. I mean, all that information about the fluorescent dye, then you using this methylturbityl ether, and yeah, that's absolutely, everything is new for me. And it just, I'm sure, like me, to all of us, it will stimulate us to read about it, to think about it, and consider using if there is a case. And I'll ask you a question, but I think just before that, I would just like to acknowledge 2 important things. One is, I'm so happy that I invited you to give this talk, and you had enough time to present your thoughts. That's number 1, because we all have certainly learned something new. That's number 1. Second important thing is, we are so fortunate that we have colleagues attending not only from the southern and eastern part of Africa, but we have colleagues joining us from West Africa, from India, from Caribbean islands. So we are really fortunate. And Martin, what else you have also highlighted is that you had significant general surgery experience, including laparoscopic surgery experience before you became a pediatric surgeon. And that's how you could build up on your pediatric laparoscopic skills. And I'm so happy that, I mean, see this, I've known you for over 20 years. And this has come step by step. And you have correctly said that 2-incision laparoscopic surgery or single-incision laparoscopic surgery is possible, but it can also have problems. And another important thing which is relevant mainly to our country is that majority of our trainees are not trained general surgeons. You people, I can say my generation or a generation older, we're all qualified general surgeons with significant experience before you trained as pediatric surgeons. So I think what word of caution I would like to give to the younger generation of trainees and pediatric surgeons, that luckily cholecystectomy is not a common operation for pediatric surgeons. So if and when you need to do cholecystectomy, please, if you have a hepatobiliary surgeon or a senior general surgeon who is more used to operating in that area, please get that colleague to assist you. That will certainly reduce the number of bile duct injuries and will reduce the number of complications for your patient significantly. So Martin, my only one question I have is, what dilator did you use for that second patient? Or
yeah, we use the dilators that we use to dilate the common bile duct in adults. They also have dilators, and there are also balloon dilators, but this was done about 3 or 4 years ago, and as far as I know, I think we didn't use the balloon dilators, but certainly that will also be a good option.
I see, but you could get a dilator which was small enough for that infant.
Yeah, with the help of the gastroenterologist and the urologist, we managed to get something, a guide wire small enough and something to put over that wire.
No, that is very interesting. You see, I mean, you investigated, you spoke to colleagues, and then you found out the best solution for that baby.
Yeah, exactly.
Yes. No, Martin, on one-on-one basis, I will get a little bit more information from you about the fluorescent dye, which we would like to at least keep it available if and when we can use it. And I would again encourage my younger colleagues working in our department in East London to make an appointment with you and spend a week, maybe 2 weeks with you, just to learn even the principles of these laparoscopic surgery and the new concepts. So you will hear from us in the due course of time.
Maybe if we have the new 4K camera with the system, which is going to happen this year, hopefully.
Yes.
We will be the first Mediclinic hospital to acquire this. So but we've worked on that now for 2 years to try and convince them to give us the system. But I will let you know if we have the system, and obviously the adult surgeons is also going to use it.
Yes.
I don't use, maybe I do 2 or 3 gallbladders a year. Most of them are asymptomatic, but just to come and have a look how it works. I'm also sort of, many times we're not sure about the blood supply, if you do a colon, pull up or what they call or bypass for esophagus atresia to see if the blood supply is good, that sort of thing. Or even Hirschsprung patients, if you do pull through to see is there enough blood supply on the tip or whatever, any anastomosis. The adult surgeons use that a lot to look at the blood supply before they do anastomosis with this system. So I'm very I hope we will get it soon, and we'll share it with you when we have it.
No, I think, Martin, that just sounds like a very fascinating new advent, which if we can afford it, it will certainly add to our understanding of the operative anatomy and the blood supply. And I'm sure it will make surgery easier and it may also reduce the complications.
Yeah, for sure.
Martin, there is one question typed here, but I want to ask you one more question before that. What is your approach to asymptomatic gallstones in a child? So the child does not have hemolytic disease, does not have any predisposing cause. Ultrasound was done for some abdominal pain, vague, no jaundice, and you see gallstones. What would you do?
Yeah, and if the child is asymptomatic, if you look at the literature, if you take all those, only about 6% of them will develop complications.
Yes.
So I will feel very reluctant. It's like adults also that they say don't take out the gallbladder if it's not symptomatic. There are certain indications. I'm just thinking, if you look at the textbook, also they say if it's a single gallstone more than 2.5 centimeters, if it's a child that's going to get maybe a kidney transplant or a liver transplant or so, and he's got gallstones, maybe it's a good thing to remove his gallbladder, you know, things like that.
Yes.
I think there are a few such indications, but most of the time that's, I think in the United States, by far, the most common indication is biliary dyskinesia. You know? And yeah, by far, actually. So, you know, when you tell the parents, look, this child's ejection fraction is not very good, you know, but I can't guarantee that his pain is going to go away. It's maybe a 70% chance, then they don't want to come to take out the gallbladder, you know.
Yeah.
So I don't know how they convince the parents, but most of them don't want cholecystectomy just for abdominal pain that doesn't have 100% outcome.
Yeah, no, thank you. I just asked the question for this specific reason, to alert our young colleagues that do not take out gallbladder just because you speak gallstones. And you and I are laughing because we know how our American colleagues are bound by insurance. Anyway, there are two questions. I think you may have partly answered one, but I'm just going to ask them again. What could be the cause of stricture in a 3-month-old baby in the CBD?
Yeah, we call it a single, you know, congenital stricture.
Yes.
But we never had a reason for that. I think if you have this book of Davenport, I think you all have this. We have this surgery of the liver from Davenport.
Yes.
Yeah, there's quite a bit about strictures of the common bile duct.
Yes.
You know, you can go through that, but we couldn't find a reason for this child. And luckily, it didn't reoccur. We see the child for a year or more.
Yes.
And the stricture was gone completely. You know, we initially placed a, now I don't think we've placed a stent there, but you didn't need a stent, but a stent is also a possibility, especially in older children. The gastroenterologist likes to put in stents in the bile ducts.
Yes.
So the possibility in older children to stent that stricture.
Yes. And Martin, I haven't read Mark Davenport's book, but my just logical thinking says that it was probably an intrauterine vascular accident, which or postnatal, which was restricted to that area and was not advanced or continued insult like to develop biliary atresia. So something like that. And yes, and I also agree with you about stents. Recently, we had a older child, I think 5 or 6 year old, who had a persistent bile leak following surgery for liver hydatid. And he also had obstruction in the common bile duct. And luckily, our hepatobiliary surgeon here, they could, on second attempt, they could do an ERCP and get a stent. And that really cleared the child's jaundice. And I think after about 4 or 6 weeks, they removed the stent. So that is quite an armamentarium. So I think second question is also answered. I need some other opinions. And I see Professor Hadley is here. So Prof Hadley, please, your comments.
Yeah, Martin, thanks. Good to hear you. And it's always lovely to listen to a real expert. What I'd like to ask you is when did you last convert from a laparoscopic approach to an open approach? And what advice would you give the relatively inexperienced laparoscopic surgeons, and all pediatric surgeons are relatively inexperienced at cholecystectomy? What intraoperative findings would make you say to him, you should convert this into an open procedure? That's question number one. Question number two is, what about acalculous cholecystitis? Have you seen it, and do you do emergency cholecystectomy, or do you just do a drainage procedure? And thirdly, just for Milind, this ICG technology is not new. They've been using it in adult oncology for many years. They've been using it in identifying lymph nodes in nephroblastoma for quite a long time too. So it's something with which there's a considerable volume of literature. Yeah, so Martin, when did you last convert?
If it's for a cholecystectomy, I can't remember, not the last 10 years. I must.
Okay, so what are you going to tell the youngster if you've got dense adhesions, if you've got bleeding, if you've got barley, if you've got what would be the indication for conversion?
I don't think bleeding is much of a problem. I think if you really don't know what's going on, you must either then I will convert, because to damage that bile duct is always leads to medical legal situation. I can also tell the registrars, if you think you've damaged the common bile duct, the thing that you have to do is phone somebody or get a general surgeon to come and have a look to try and just give you a second opinion. That's the one thing. And the other thing is, and also to tell you what to do. And in that situation, never to try and repair that common bile duct or do any surgery there, because once you've damaged that thing, you're not in the your mental thing is not so that you will do a good operation. It's a devastating complication, and you won't be able to fix that problem properly. So I think if you have this problem, ask a colleague to come and have a look and get his opinion, and then just if it's a gastroenterologist or a liver surgeon, general surgeon that has a lot of experience, maybe you can open the thing and see what's going on. But otherwise, if you don't have the expertise with that sort of expertise with you, I think just an ordinary general surgeon is also not good enough. You have to have a biliary surgeon to help you with this problem. And then I will just put in drains and quite a big drain or 2 drains, and then leave the situation that and phone that biliary surgeon to come and help you. It's not necessary at that stage to do anything. And
that's good. That's good advice, Martin. Thank you.
Well, the ICGs, I think I can't remember when, but when that laparoscopic course was in Johannesburg a few years back, they also stores also showed that you can diagnose NEC with a camera. But so it's not new, but laparoscopically it's new because it's fixed. It's now a fixture on some of these cameras. So before the laparoscopic situation, they've used it maybe, but it's quite new now that you have it on the 4K camera and on the as a fixture.
Yes, thank you, Martin, and yes, Prof Hadley, thank you for that clarification. Yes, we are aware that those fluorescent dyes have been used mainly in oncology for many years, and its use, as Martin has clarified, in laparoscopy is quite recent. And Martin, I think, can I just ask Prof Hadley's second question to you? What is your approach to acalculous cholecystitis?
I must say, I think in the late 1980s, somebody asked me, a thoracic surgeon, they did open heart surgery, and they asked me this. They thought the patient had acalculous cholecystitis, and then it wasn't sure on all the tests. Is this a situation? It was a sick patient. And then I've asked one of the gynecologists, because they were the only people actually who knows how the laparoscope works, to come and have a look. So they've diagnosed with the camera acalculous cholecystitis in the 1980s already. And not because I was clever, I couldn't make a diagnosis, don't know what's going on. And then I asked a gynecologist to have a look, and he diagnosed the condition. Most of the, if it's not, I think I will remove the gallbladder or try and remove it laparoscopically if it's possible. If it's, I don't know Prof Hadley agrees with that. Most of the times it's a very sick gallbladder, so I'm not sure if a cholecystostomy will help, but many adult patients with cholecystitis and so on, they do cholecystostomy or put a pigtail into that gallbladder to try and drain it. I must say I didn't operate any patients so far with acalculous, any children with acalculous cholecystitis so far.
Yeah, I would agree that the one or two that I've seen have both been in critically ill children who really weren't fit for very much other than a cholecystostomy under local. You're never quite sure what kills them, their original disease or the acalculous cholecystitis.
Yeah, that's right.
Yes, no, thank you, Martin. And I also liked that you mentioned about cholecystostomy, which may sound like a bailout procedure. But I think, again, the young surgeons need to know that sometimes it is better to bail out and make the, give the chance for the patient to get better, stable. You can then investigate a bit further. And as you correctly said, then next time when you want to go in, get a hepatobiliary surgeon or an experienced general surgeon to be with you when you go in again. And also that you spoke about subtotal cholecystectomy. And I think it is important for the younger ones to know that it is patient safety is more important than the surgeon's ego. And I'm sure you will agree with that in your comment.
I must say I did when I did adult surgery, I did quite a few subtotal cholecystectomies, and it's a very good bailout procedure.
Yes.
Just where you can see the gallbladder, stop there, but don't go deeper. Just even cauterize the mucosa of the rest of the gallbladder.
Yes.
And just put in a drain there.
Yes.
That's it's a very good option.
Yes. Martin, one more question. In blunt abdominal trauma, you explore for something else and you see that the gallbladder is injured. Let's say like a tear at the fundus, at the fundus. Would you repair it or would you take it out? I'll tell you the reason for me to ask you this question. I had a case probably about 20 years ago. A young child who had a blunt abdominal trauma presented with peritonitis. Ultrasound showed solid organs were normal, but due to peritonitis, we explored him and we found an injury to the gallbladder, strange, isolated, and I repaired it. And there was a constructive criticism in our department. Why did I not take out the gallbladder? And I did a bit of reading around that, and there were reports of conservation of the gallbladder. So the child was just 3.5 years old. So what would be your approach, Martin?
Yeah, I must say in adult patients, I think we were taught that by Prof Mini never to just suture the gallbladder, just take the thing out,
Yes.
But if you read the pediatric literature, like even I think this textbook of Mark Davenport, they talk about taking out the gallstones and suture the gallbladder again.
Yes. Yes.
And even what we do a lot is we do cholecystostomies to do grams for possible Kasai procedure. And then I actually don't suture the gallbladder again if it's not a biliary atresia. I just put in a small catheter there and keep it in for 5 days or a week and then take it out. So maybe it's also just to put in a catheter and bring it to the outside, and then after a while take it out and it will close on its own. That's also a possibility.
Yes. Sorry, I didn't get what was the last pathology you discussed about, you described?
No, if I suspect biliary atresia,
okay,
we do a pre-operative gram laparoscopically.
Right.
So you open the gallbladder and you
Yes.
put in a whatever
Yes, yes,
catheter, and then you do the gram.
yes.
And then if it's not biliary atresia, I don't close the gallbladder. I just keep that catheter in and bring it to the outside and keep it in for for a week or so and just pull it out.
Oh, I see. Okay.
That's very safe to do that.
Yes, yes. As long as the distal passage is clear,
Yeah,
once
there's
you
no
take this
problem.
out, this fistula will close. Okay,
Yeah,
that's
typically.
yeah, that is interesting and makes sense. I will now invite Dr. Yashoda Manikchand, our consultant pediatric surgeon, to give her thoughts, comments. Yashoda?
Hi, Prof. Yes, thank you, Prof Van Niekerk. That was very, very educating to me, especially because of the laparoscopic work that you do. And I think we don't see gallstones in children. And actually, I've only seen acalculous cholecystitis in very sick neonates. And we didn't take those out. Usually they got better as the child got better. So it's interesting to hear your perspective on that as well. And then just to hazard a guess at this stricture in the 3-month-old baby, maybe it was pancreatico-biliary malunion, which would cause reflux of the pancreatic enzymes into the CBD. But yeah, I just thought about that. I don't think I have any other questions. Thank you.
Martin, you need to unmute yourself. Sorry. Yeah,
Hello,
Martin, you can answer Yashoda's question, but then I think it's time you can give final concluding remarks.
Yeah, I agree. It must be a congenital thing, or maybe a long common channel with reflux or something like that. If you look at in the textbook of Davenport, there's a whole list of things that can cause the stricture of the common bile duct. Yeah, thanks for asking me. I think we're not too used to take out gallbladders laparoscopically. If you have such a case, especially then, and you can ask a general surgeon just to come and assist you, because they do this operation every week. So that's what I will do if I start now with laparoscopic surgery and don't have the background of general surgery, because we definitely don't see enough cholecystectomies to make us an expert. I can also say that if you look at the common bile duct injuries, about 40% of these injuries were caused by surgeons that had more than 10 years laparoscopic experience. So either the difficult or the easy gallbladder that can land you into trouble. But as I've said, get a general surgeon just to come and help you with one or two of these when you start doing laparoscopic cholecystectomies.
Martin, thank you very much again. That's very sound advice. And I have enjoyed, I'm sure each one of us has thoroughly enjoyed and learned a lot. And I really appreciate you filling in without our junior presenting. And we will certainly rope you in next year for some other interesting topics. And we will wait to hear from you when you have the new camera. So at least one of my colleagues, junior colleagues, can come and spend some time with you and learn from you. So thank you. And for all the attendees, thank you very much for attending. And next week, the meeting will be open only for the staff of our department. The following week, Dr. Selo Machaya, who is our consultant pediatric surgeon, he has done his mini dissertation on gastroschisis in the Eastern Cape, and is going to share his experience from his dissertation. So thank you, everybody. I'm recording the meeting and I will post the link on the relevant groups. Thank you again. Bye-bye.